It is none other than Dr. Naveen Malhotra, the past Honorary Secretary of our ISC National. And Dr. Naveen Malhotra, there is no need of introduction, and he knows everybody knows about Dr. Naveen Malhotra. And he is Senior Professor, Head Department of Cardiac Anesthesiology and Pain Management Center, PGIMS Rohtak, Haryana, India. So it's over to Dr. Naveen Malhotra, sir.
For the warm introduction and kind invitation. When this topic was given to me, obesity and anesthesia, I thought Dr. Manjunath is playing prank on me. Why this topic to an obese anesthesiologist? So I started preparing the lecture, but I'm happy to share with you, in last 3 weeks, when this topic was allotted to me, I have lost 3 kgs also. So the term obese is derived from the Latin word obesus, meaning flattened by eating. And the 2022 update on epidemiology has clear-cut shown that obesity is a twin COVID-19 pandemic, and COVID-19 is receding, but obesity is not. And the WHO data over the years have shown this, proven this, especially for the Asian countries. And now obesity is a global epidemic. For us as anesthesiologists, there are 2 worst enemies, an obese patient and patients who are having COPD. So basically, it's simply an imbalance between intake and the consumption, which can be because of multifactorial, whether it is a sociocultural, physiological, psychological, metabolic, endocrine, maybe because of hypothyroidism, insulinoma, genetic factors, patient on drugs like corticosteroids, antidepressants, OCPs, and behavioral components, which all result in deposition of excess adipose tissue. In males, it is an android obesity, and in females, it's a gynecoid obesity, more around hips, buttocks, and thighs. In males, more around the abdomen. Now, this classification is important for us because there are different indices, but we commonly use BMI, which is the weight and the height, and anything more than 30 worries us. So, BMI of more than 30, we have to be cautious because that increases the perioperative risk. There have been numerous classifications of morbidly obese, 35 BMI with comorbidities, or morbidly obese with BMI more than 40 without any comorbidities, and then super obese between 50 to 60, and super obese between 60 to 70, and more than 70 in hyper obese categories. And there are other indices. In addition to BMI, ideal body weight, which is height minus X, which is X is 100 for males and 105 for females. Lean body weight is important for us to know because we usually try to calculate the drug not by the actual weight but by the lean body weight. And lean body weight is total weight minus the fat mass, that is 80% in males and 75% in females. So suppose somebody is suppose is 100 kg in as a male, the lean body weight will be 80 kgs, and in a female it will be 75 kgs. The other measures are done usually by the athletes, the skin fold thickness, waist hip ratios, and we should be worried about the pathophysiological changes occurring in obesity, and I'll try to cover the clinical aspects along with these. And let's do a ABCD approach. Airway, we know in obese patients there will be limited atlantoaxial and cervical movement, there will be increased neck fat pad, short and thick neck, reduced thoramental distance, large size breasts making the laryngoscopy difficult, oral cavity and pharyngeal fat will be increased, and modified Malhotra grading will be in the grade of 3 or 4. And the predictors of difficult intubations are neck circumference, if it is more than 70 inches in a male and 16 in females, and modified Malhotra grade of 3 and 4, they pose a difficult airway. So all these factors pose the obese patients as a difficult airway. In the airway, anything can be difficult. The mask ventilation, the laryngoscopy and intubation, but the clinical experience shows that mask ventilation is most often difficult, and majority of the times laryngoscopy and intubation is easier than the mask ventilation. But we have to be prepared for all the 3. These patients have got associated obstructive sleep apnea, which is 10 seconds or more of cessation of airflow despite continuous respiratory efforts against a closed glottis. More than 10 seconds of obstruction more than 5 hours a day, more than 30 times in a night. So these are important for us. And how to suspect in PAC? Ask for the history of snoring, daytime somnolence, and history of headaches. Definitely confirmatory is polysomnography. And it is important for us because there are high chances of perioperative hypoxia in these patients. And these patients will require perioperative non-invasive ventilatory support in the form of CPAP or BiPAP. So what happens is, as soon as the patient goes off to the sleep, there is loss of neuromuscular tone, decreased pharyngeal muscle activity, the airway collapse, leading on to apnea, and then apnea leads on to hypoxia and hypercarbia. Increased ventilatory effort will result into that. Patient gets arousal from the sleep, increased tone of the pharyngeal muscles, airway open, and the hypoxia and hypercapnia are corrected. And then this cycle keeps on repeating throughout the night. And we can severity of OSA, if there are 5 to 15 episodes, it's mild, 15 to 30 it is moderate, and if there are more than 30 episodes per hour, it comes into severe form of obstructive sleep apnea. Obesity hyperventilation syndrome, OHS, it is a sequelae of obstructive sleep apnea, and it is characterized by decreased ventilatory response to CO2. Hypercarbia is there, but still the response is not there. So it will be characterized by hypercarbia, hypoxia, polycythemia, respiratory acidosis, and eventually leading on to pulmonary arterial hypertension and right heart failure. And the extreme form of OHS results in the Pickfinian syndrome, which is characterized by obesity, daytime hypersomnolence, arterial hypoxemia, polycythemia, hypercarbia leading to respiratory acidosis, pulmonary hypertension, and RVS. Breathing. It is characteristically a restrictive type of disorder. A restrictive breathing pattern is there with decreased chest compliance, almost reduction in all the lung volumes, especially the FRC, which results in rapid desaturation in these patients. There is increased work of breathing, increased oxygen consumption, increased intrapulmonary shunt from a normal of 2.5 to 5% to up to 25%, and VQ mismatch. In circulation, there is increased cardiac output, 20 to 30 ml per kg, increased blood volume. These patients often develop hypertension, atherosclerosis, ischemic heart disease, and obesity cardiomyopathy. These patients often land up in biventricular failures, arrhythmias as a result of fatty infiltration of the conductive system. There is a hypercoagulability, sleep apnea syndrome, sinus bradycardia during apnea, and sinus tachycardia when ventilation resumes, as I have shown you in the previous slide. And as these patients are often on diuretic therapy, they can develop hypokalemia also. So there is in the left ventricle, there is increased LV load, increased cardiac output in stroke volume, leads on to increased LV load dilatation and compensatory left ventricle hypertrophy. But this LVH is often eccentric. There is decreased LV compliance. There occurs chronic fluid overload, and ultimately patient lands up into CHF. And in the pulmonary side, because of obesity, OSA and OHA occurs. Patient has suffering from hypoxia, hypercapnia, and polycythemia, leading on to pulmonary arterial hypertension and right ventricular failure, and in the pulmonary venous hypertension, left ventricular failure. So these patients are predisposed to biventricular heart failure. In the CNS, there is decreased central respiratory drive, there is somnolence and hypercarbia. Drugs. Anesthetic drugs are affected by fat mass, so we have to consider dosing according to lean body mass. As I told you, it is 80% of the total body weight in males and 75% in females. And there is altered drug distribution, binding, metabolism, and elimination. And dosing of all drugs is by lean body weight, except for thiopentone, succinylcholine, dexmedetomidine, and neostigmine. These patients have got difficult venous access, they have got difficult positioning and transport. Neuromuscular blockers, pseudocholinesterase levels are increased, and there is increased extracellular space. So, as I told you, succinylcholine dose may have to be increased, and neuromuscular blockers should be given by aided by neuromuscular monitoring, as nicely elaborated by the previous speaker. Opioids, and the pharmacocontent of fentanyl is unpredictable, and fortunately we're soon going to have remifentanil in the market, so that is the analgesic agent of choice. So the bottom line is overdosing is very, very common in obese patients, as we tend to inject by the total body weight, but we should administer drugs on the basis of lean body weight. In the endocrine or these patients have got associated endocrinal disorders like diabetes, hypothyroidism, metabolic syndromes, deranged renal functions, and hypertensive retinopathy. We have to be very, very cautious for fluids in these patients because they tend to dehydrate fast, as well as they tend to go into failure also if fluid is given at a rapid phase. Although the total blood volume is increased, but volume per weight basis is less than in normal in non-obese patients. Normally it is 70 ml per kg, but in obese patient it is 50 ml per kg. So these patients are pre-fluid and blood loss tolerant in patients, and we have to ensure that they don't have prolonged fasting. At the same time, rapid replacement of fluids can cause cardiac decompensation. In GI, it's predominantly an acidic pH. pH is less than 2.5. There is delayed gastric emptying, increased gastric residual volume. All these places these patients at increased risk of regurgitation and aspiration. These patients have associated GERD, decreased hepatic clearance. Because of obesity, there may be development of inguinal hernia, hiatus hernia, fatty liver, and nutritional deficiencies of vitamins and calcium. These patients are in very, very hypercoagulable stage, and there is venous stasis, there is increased risk of DVT, subsequent pulmonary embolism, and it is said that thromboembolic complications incidence is twice in obese patients. The metabolism of inhalational agents is all limited, as slight decreased, whether it is halothane, isoflurane, and sevoflurane, and the halogenated agents are stored in liver and fats for a longer period of time, even after completion of the surgery. Nephrotoxicity because of the high fluoride concentration is another risk. Desflurane is the agent of choice because of low blood solubility and rapid induction and emergence. A word about laparoscopy and anesthesia, because pneumoperitoneum causes systemic changes otherwise also, and the patients are most of the time in Trendelenburg position. So systemic vascular resistance is increased with increased intra-abdominal pressure, and compression of IVC occurs at IAP more than 20. So we have to ensure that in patients who are morbidly obese, the intra-abdominal pressure should be as low as possible, 12 to 14, and we have to be taking care of the monitoring of the intra-abdominal pressure as well as the body posture, because it can further worsen the respiratory mechanics, oxygenation, and ventilation. But it's not over yet. There are many, many other things these patients have. They are suffering from osteoarthritis, back pain. So all these things have to be taken while taking the patients for the surgery. And you have to take care of all the pressure points, whether they are the genitalias, elbows, feet, any pressure point, they have to be padded. You have to take care of the skin fold infections also. These patients have got associated varicose veins, subcutaneous edema, and because of the limited mobility, other factors are there. These patients may be in psychologically altered state because of the depression and anorexia nervosa. Just touching about obstetric patients, because obstetric and pediatrics is beyond the scope of this lecture. These patients have got higher incidence of preterm labor, gestational diabetes mellitus, and preeclampsia. We often tend to prefer regional anesthesia, but we have to be sure about that. In regional anesthesia, it is technically difficult because of the obese patient. We may require longer needles. There is overall decreased requirement of anesthetic agents, and there is difficulty in positioning. So sitting position is commonly preferred. And nowadays, image guidance has come up in a big way. Whether you use USG or fluoroscope, both are useful. But dear students, even if you are planning regional anesthesia, be fully prepared for general anesthesia. So we have got enemy in front of us, and what we have to do is we have to be prepared to face this enemy. So thorough screening for sleep disordered breathing, OSA, use of CPAP in the PAC checkup, and the stop bank questionnaire. If the score is more than 5, it definitely tells about the increased risk. So S is the history of snoring, T is feeling of tiredness, O is whether you have observed, somebody has observed you choking or your breathing stopped during sleep, and P whether you have got any other history of hypertension. B is BMI more than 35, A is age more than 50 years, Next reference N, 17 in more than 17 in males and 16 in females, and G is gender, whether you are a male. So all these are risk factors, and if there are more than 5 positive responses, it places the patient at the increased risk of perioperative morbidity. Always do a careful respiratory assessment about the dyspnea, METs, associated history of COPD and smoking, which has to absolutely be stopped. Cardiac assessment about history of PND, orthopnea, hypertension, angina, and ischemic heart disease, and other comorbidities. Do a thorough examination of the airways, chest and CVS, and ask the patient which is the most optimal, comfortable position for them. Most of the time, the patients will say that they are head-up posture, and we have to ensure that these patients are majority of the time placed in head-up postures. Though in post-operative period, they can be placed in lateral and prone position also, but most of the times, these patients will say that we are very comfortable with head-up postures. Take care of the hemodynamic indices, and now everybody has got a pulse ox in the pulse oximeter in the PSC clinics in their pocket. So do have the room air saturation of the patient documented, and in the PSC checkup see for the venous accessibility, because these patients may have got difficult venous access. So which veins you are going to secure in the OT the next day. And all the investigations have to be done, complete hemogram, blood glucose, RFT, serum electrolytes, liver functions, thyroid functions, ECG, chest x-ray. ABGA pre-op is useful to us, pulmonary function test, bedside also. Echocardiography and polysomnography if it is indicated, and imaging of the airway with soft tissue x-rays are quite useful to us to know how much is the fat and how much the airway obstruction, whether it is occurring or not. And nowadays we are using USG also, and if there is a more than 2.5 centimeter of pretracheal adipose tissue, it indicates that you are going to land up in some sort of difficult intubation. So what all is needed is an adequate equipments, well-trained personnel who are experienced, and majority of the times for morbidly obese patients, it is recommended that you go for 2 anesthesiologists. So proper key points for preoperative period to be considered are that these patients should not be in prolonged fasting, as I have told you. Aspiration prophylaxis as per the institution protocol. Usually ondansetron and metoclopramide both are given. Avoid sedatives because they are very if patient is hyper anxious, then only use some dose of midazolam. Incentive spirometry should be instituted as for a longer period as possible, and head up position. Do ask about any history of oxygen support in the preoperative period, and for the thromboembolism prophylaxis, patients are usually put on heparin, and in the perioperative period, pneumatic leggings and compression stockings are placed. Positioning at times, standard operation tables are not sufficient, and you may have to combine 2 tables side by side, and always please note how much weight our table can carry. Some tables can carry a weight of around 200 kgs and some can up to 450 kgs. That you should know about the specifications. And patient should not slip from OT table during, if you making the patient OT table lateral, so they should be properly strapped to the OT table. Induction, prolonged pre-oxygenation, and along with para-oxygenation while you are attempting laryngoscopy with nasal prongs in the nostril at a rate of 2 to 4 liters per minute. And ramp position is very useful. Have the difficult airway cart ready. Each and every equipment, whether it is the fiber optic bronchoscope, whether it is the supraglottic airway devices, whether different types of laryngoscope loads, bougies, airway exchanges, exchange catheters, cricothyroidotomy, everything should be there as per the institute protocol. 2-hand mask ventilation is commonly done. At times 2-person mask ventilation is required. One is holding the mask, other is giving the jaw thrust and pressing the bag. And if required, you can use supraglottic airway devices for ventilation also. And simultaneously, you can combine, just close the APL wall and give some amount of CPAP. So ramp position, aim is to have ear to sternal notch in line, and you put the roll gauges on sheets under the shoulder and the different sheets under the occiput. We may anticipate difficult laryngoscopy and intubation, so video laryngoscopes are quite useful, and supraglottic airway second generation, they are also useful. If required, you can go for awake fiber optic intubation depending upon your choice of the technique, but do avoid laryngoscopic response, hypotensive tachycardic response to laryngoscopy, and ensure that patient is receiving some sort of oxygen during the period of apnea. The ventilatory settings, use of PEEP and FiO2, that has to be titrated according to the patient, how much tidal volume you want to give, what PEEP you want to give, and what FiO2, maybe ranging from 0.3 to 0.5 to 0.75. They have to be ensured on the perioperative period. And always try to maintain head-up position. The standard monitoring is to be done, and invasive monitoring at times has to be done because NIBP cuff is not sufficient enough to measure the BP, and you may have to go for arterial cannulation. Administer drugs as per the lean body weight. I repeat, all the drugs are to be given by lean body weight except for thiopentone, succinylcholine, dexmedetomidine, and neostigmine. And go for goal-directed fluid therapy. Reversal has to be done in head-up position. Awake extubation is preferable. Do gastric decompression before the extubation. Clear airway excretions thoroughly. Give an antiemetic before extubation. Always use multimodal analgesia, restricting or decreasing the dose of opioids. Ensure that your recruiting measures and use of CPAP is there. It is safer to extubate over airway exchange catheter with intubation cart ready. In the recovery room, have a propped up posture. Continuous oxygen support is given. CPAP and BiPAP, if needed, has to be given, and DVT prophylaxis is instituted as per the surgical procedure. Avoid sedatives, watch for the ventilation, and always prefer early mobilization. So to I summarize my talk, that these patients who are obese, they present difficulties with venous access. There are mechanical problems because of the size and weight of the patient. There are difficulties in localizing the subarachnoid and extradural spaces. There is more extensive spread of local anesthetic solutions in the subarachnoid and extradural space. There are difficulties during mask ventilation, at times during tracheal intubation also. Reliable IBP monitoring is difficult. Invasive monitoring may be required. During the period of apnea, there is increased risk of hypoxia. Rapid desaturation may occur before tracheal intubation. So pre-oxygenation and para-oxygenation is helpful in preventing desaturation. Rapid dehydration and poor tolerance to hypovolemia is common in these patients. And also cardiac decompensation with fluid overload is also not uncommon. There is increased risk of postoperative hypoxia and respiratory problems, so we have to be very watchful, and always ensure that you give protection against DVT and pulmonary embolism. So I conclude by saying obesity, it is at best preventable. If not preventable, it is reversible.